Brigham Education Institute. I'm Glenn Gaviola, the Program Director for the Diagnostic Radiology Residency Program today, and we will be talking about space education and interleaved learning. Our goals and objectives for this session will be to define spaced education and interleaved learning, provide examples from the cognitive science and medical education, and finally help discuss how you as an educator can help provide this experience for your learners. Would like to start with a short YouTube video just explaining a little bit more about spaced learning in medicine from the open.osmosis.org organization. So let's start with defining and understanding the evidence behind what space education is. So space education, as you just learned, is learning information by studying material with having distinct time periods between each study period. In the literature or in nomenclature, you may hear the term spaced learning or spaced repetition. And I'd refer you to this article by one of our colleagues here at MGH and the partners discussing about the cognitive science of learning, concepts and strategies for the education and learner for additional information. Now compare and contrast this to the idea of mass learning, which is learning information without significant interruption. And most of us may understand this using the terms cramming, or you may see it in where we have intensive type courses. And we'll see that a lot of the continuing medical education is replete with many of these, including boot camp type courses, board review courses in preparation for medical boards in many different specialties. And I must say that my own specialty in radiology also offers these kinds of mass learning options. So as we learn, spaced education is really superior to mass learning. So in general, at any given time point, you will learn something maximally. And then over time, if you don't review it, there's a forgetting curve. So with the concept of spaced education, over time, we want to minimize that forgetting curve and maintain our retention so that in succeeding intervals, we actively review information again so that our retention is increased. And over time, we want to review things that are less familiar more frequently and things that are more familiar less frequently. And again, the goal is to review right before we start forgetting. So in terms of the literature, thinking about how space education is more superior to mass learning, this has been proven to be regardless of the type interval that we have. And intuitively, this makes sense so that 4 30-minute study sessions are much more favorable than a one-time 2-hour study interval. So this was first demonstrated in the literature, in the surgical literature, looking at teaching surgical skills from an article in 2006. Where surgical residents were randomly assigned either a day-long intensive session learning the suture versus 4 different sessions held over several weeks. And the conclusion of this paper was that there was better retention and application after spaced repetition. The study was one of the first to assess the impact of an alternative method, again, where learning was distributed over multiple training sessions. And they noticed with their outcomes that the residents and trainees perform better on retention tests and also during a live actual demonstration. And the conclusion was that residents retained and transferred skills better if they were taught in a distributed manner. And this was important because it allows us as educators to really think about restructuring our training schedules to allow more of a distributed practice than this concept of mass learning. Second, longer interstudy intervals have been associated with better long-term retention. And the key here is that there needs to be some retention along the intervals. So if we think back again to our curves, our learning curves, we'll notice that it's really important that we try to review things before we've completely forgotten them. So you certainly don't want to have too much time elapse so that there is absolutely no retention left before we continue to review a topic again. And this was shown also to work equally well with both verbal and motor tasks, so either new knowledge or skills. Oftentimes the greatest gains were made with lower complexity. So there is an interesting concept in what I call the learner's fallacy, in that learners generally prefer mass learning and believe it to be more effective than spaced education. And this is despite data that is shown to be contrary to this. You're looking at test performance, where the opposite has been demonstrated. So I refer you to Make It Stick, The Science of Successful Learning, which is an excellent monograph from the medical education literature looking at science of learning. And this was brought to us by 2 cognitive psychologists summarizing the majority of the recent science behind spaced education. And essentially, When we looked at massed learning, so these boot type and intensive courses, this really acts on only short-term memory. And as we saw that over time without review, the information can be lost. Versus spatial education, we're really looking at long-term encoding and consolidation of information so that it is retained over a longer period of time. And again, the important part is to learn things after you're just starting to forget it. And as a result of that, this learning tends to be very effortful and requires retrieval after a little bit of forgetting, but in essence, this strengthens memory. So again, learners may dislike this because it may seem like it's harder work. Now let's switch gears to talk about interleaved learning, thinking about the definitions and the evidence behind interleaved learning. So Make It Stick talks in much greater depth about this, and interleaved learning is defined as the practice of mixing two or more subjects or skills into a learning session. Other terms you may see in the literature include varied practice. So let's think about an example. So in baseball pitchers, a batter was tested, and they looked at two different groups. So they took one group and had batters basically receive 15 fastballs, followed by 15 curveballs, followed by 15 changeups. That this is really the concept of seeing one thing over and over again and feeling better at it before you move on to something different. And this was compared with actually having random pitches, having a fastball followed by a curveball and maybe another fastball and then a changeup. And what they found in pitchers is that there was better performance with random pitches because this formed a concept of spaced practice. Learning was much more effortful. And this is, in actuality, more reflective of the real world rather than having one thing and being better at it, but actually changing things up. And this seems to be a little bit counterintuitive to what many of us may think. In medicine, this was recently reviewed in my specialty in radiology, where they looked at the effect of massed versus interleaved teaching methods on performance of students in a radiology clerkship. In this group, medical students were randomized to review 66 chest x-rays. All of them initially showed 6 normal chest x-rays, and the groups were then divided between the massed grouped learners, where learners were shown 6 chest x-rays of one single disease entity consecutively for 11 times. And this was done with 11 different disease processes, and you could see below what those disease processes are. This was compared with a second where the learning was interleaved, in which the medical students were given 3 blocks of 22 randomized diseases, where they had 2 diseases per block. What did this show? Let's take an example of exactly what the medical students saw. So in the beginning, they were shown a normal chest x-ray, and they were shown 6 of those just to get a better sense of what the anatomy was. So the first group was the mass practice group. So they were shown one disease entity 6 times. So for example, a chest x-ray was showing a pleural effusion. So you can see there's blunting of the claustrophrenic sulcus and opacity. And another example here, and in the left chest. And this went on until 6 different chest x-rays were shown demonstrating different types of pleural effusions. Then it was on to the next disease entity, so the lung masses. So here's an example of a chest x-ray showing a large left hilar mass in the lung, and a separate but smaller one in a separate patient, and one in the right side, one in the lung apex, another one on the left, and finally another one on the left side. And this went on for 11 disease processes for a total of 66 chest x-rays. Now let's look at the interleaved practice group and how they actually were shown these. They would be shown one chest x-ray showing a pleural effusion, then another chest x-ray talking about congestive heart failure with a big heart and pulmonary edema, followed by a different disease entity with a lung mass here showing a right apical lung mass. And finally, a different disease entity with pneumonia. And this was done for the 11 disease entities, and again, a maximum of 2 disease process per single opportunity. So here's another lung mass, here's a different type of pleural effusion, another example of CHF, and another example of a pneumonia. And after looking at these randomized groups, both of them were then tested with 24 randomized chest x-rays, where they were presented with 2 normal chest x-rays and followed by 2 of each disease entity, 1 new and 1 old. And the outcomes were that the interleaved group actually performed better on the exam than did the masked group, with a statistically significant value as you see here. So comparing the interleaved and masked groups, the average overall score was 57% compared with 43%, and the recollection score was 61% versus 47%, both within showing statistical significance. And the conclusion was that interleaved method of instruction leads to better results than the masked method across all levels of education. So the conclusion was disease patterns in random order in the interleaved method led to significantly improved image recognition compared with patterns of disease shown in group using the masked method. So let's take a look at an example of where spaced education and interleaved learning are actually in practice now. As part of the American Board of Radiology, I'm required to maintain my certificate, and part of that maintenance of certification process requires that I and other radiologists must pass a cognitive examination every 10 years. Recently, our ABR reviewed the entire process and actually replaced the current 10-year requirement of this proctored exam with an online longitudinal assessment, incorporating modern and more relevant adult learning concepts, including that of spaced education and interleaved learning. This was an opportunity to offer real-time feedback and remediate gaps, and this was using a model that was piloted and evaluated by the American Board of Anesthesiology, where instead of a test every 10 years, the diplomats would receive weekly emails with links to questions, which they must immediately answer, and they would be given feedback on the actual correct answer, the rationale, and a critique of the answers, and any brief educational material. So to further understand this, I looked at the American Board of Anesthesiology to see what they do, and this was piloted using the MOCA Minute. So instead of a 10-year exam, the diplomats were given 30 questions per quarter and had to answer 120 questions per year. And they were given 1 minute to answer a question, and they were shown the number of questions that were answered on the dashboard with the percentage of questions that were answered correctly, so they were able to monitor the progress over the course of each quarter and the year. And in addition, for every question they answered, they were given feedback immediately about their questions. If questions were answered incorrectly, there would be additional questions later on that same topic for continuous reassessment, and when questions were answered correctly, a similar question in the future would be seen to help retain knowledge. So if we think about this, this is actually a nice example of spaced education in which, rather than waiting for an examination every 10 years, our knowledge retention would decrease. Instead, by getting questions on a frequent basis, you're able to maintain your knowledge retention much higher. And similarly, with questions that were more familiar, there would be a longer interval compared with questions that had less familiarity, which questions would be asked more frequently. So you can learn more about the MOCA Minute process by the American Board of Anesthesiology by referring to their website. So now that we know more about spaced education and interleaved learning, how can we adopt this as educators locally? As the program director of the residency, we looked at applying this into our training programs. Every day at noon, our residents received dedicated didactic teaching from many faculty members. And traditionally, we've offered mini courses based on our radiology subspecialties, in which each subspecialty gets 3 to 4 weeks at a time to teach their section. And for example, here we would have a typical month where we'd have breast imaging presenting their conferences for 3 weeks, and then this would change, and neuroradiology would then go on. Part of this was we decided to change this using our concept of spaced education to a monthly template in which each of our divisions were actually giving conference once a month. And this is in keeping with what we would expect for much more retention over the long term. In addition, we reviewed our clinical scheduling. We traditionally had a 3-month pediatric block that occurred one time during the 4-year of residency. And with that, we decided to split this up and instead have a 2-month followed by a 1-month pediatric block that were separated by 1 year. This helped encourage our learners to relearn information from the last rotation and allows them to reach back to concepts of learning that were covered earlier when learning was decreased in order to maintain their retention. Other things, you can encourage your learners to learn a little bit more about what's happening in the literature with spaced education and interleaved learning. So the research I presented about the chest x-ray findings we discussed during a medical education journal club co-sponsored with the Brigham Education Institute. So this is a great opportunity for learners to also partake in looking at how medical education is important. We showed the video that you saw earlier with the link. And finally, as a program director, I meet with the residents semi-annually to review their learning. And part of this is an opportunity to encourage them to learn a little bit more about spaced education, to review their study habits, and also to encourage them to use the principles of spaced education. So are there drawbacks to spaced education and interweave learning? Well, certainly it takes time, it takes effort, and it certainly takes patience. It may not feel like the payoff is in the short term, but the important part is thinking about training programs are really more of a long-term effort and payoff. It is a better reflection of the real world. Again, as we know that we learn about patients through textbooks, but they may not always present the way they are in textbooks, and we need to be reflective of that. And again, despite mass practice feeling more productive, it's important to recognize that effort for learning is really what we aim for. And our goal as educators, using the paradigm of Miller's pyramid, again, is that our trainees really need to not just know or know how to do something or show us that they do it, but actually do it and perform. So our take-home points. Spaced education and interleaved learning are superior learning methods than master group practice, or otherwise known as cramming. There's strong evidence from the cognitive sciences and medical literature showing a positive impact, despite that learners may prefer mass practice, even though that may feel easier. This is now being adopted by national medical boards, and in our own local program, implementations are feasible and can be very simple. So hopefully in this short video, we were able to define spaced education and interweave learning, provide you some examples in the literature, and then show how you can provide this experience for your learners. Thank you very much.